Hello, everyone, and thank you for joining us today. This is the next in our series, Auditing Your Practice. This month, we're going to talk about the importance of auditing and evaluating your technicians. Today's presentation will include the following. We're going to discuss what exactly are technician audits, the impacts to your practice if you do not audit your technicians, case studies, benefits of auditing your technicians, and the outcomes that you should expect by doing these audits. So audits are meant to identify areas that need improvement, do gap training on those areas, and also identify strengths. And we do this by having an experienced technician or someone like us come in on several workups and assessing their accuracy, efficiency, technique, customer service, their general medical and ophthalmic knowledge. And we do this so that we can find where their strengths are, which we can give them good feedback on, and then the areas that they need gap training in. One technician may be doing everything fantastically except tonometry. She doesn't need training in refraction and history taking or visual acuity assessment. She just needs training in pressure. So in this case, we don't want to spend all the time retraining her on all the stuff she's doing right. We can just focus in on those one little part of her workup that needs some help. So it's very efficient to do audits this way. You want to have someone who has very good skills doing the audit. And you also want to be careful how you present this to the technicians who will be audited. For example, if I tell my technician team that we're going to be doing audits of their workups, they're going to be so scared and nervous that we aren't going to even see the real them working up the patients. So the better way to approach this with your team is to say, we're going to have our lead trainer so-and-so sit in with you, and she's going to just look to teach you some new tips, tricks, techniques, just kind of take you to that next level, whatever that next level is for you. And just be very casual about it and make it very positive. Before we go into the exam room, and we recommend your technician do this as well, we say to the technician, I will never embarrass you in front of the patient, because isn't that what we're all afraid of? And I would also say, I'm just going to be teaching you some tips and tricks and techniques and take you that next level. So I'm just going to sit in and observe you. And if I see you doing a skill in a way that is not clinically sound and we can't send the patient on to the doctor with the skill done that way, you're going to hear me say, can I show you another way to do that? And when you hear that, that means there was something you were doing that wasn't quite right. And just step aside and I'll step in and do the skill. And then we'll talk about it afterwards. And you watch me while I do the skill because you might figure out what you needed to do a little differently. Then after the patient, we'll discuss what the areas were that need some help, and we'll do some gap training on it. Now, if the technician needs a big host of gap training or a very complex skill discussed and retrained in, we don't want to mess up the schedule or the clinic flow. So we're going to tell them that we're going to meet with them at the end of the day and just make a note about the skill that needs some attention. So this is really great because each tech gets just what they need. And then the trainer or the evaluator should provide a report to the practice about each technician. We do this when we go into practices and we do technician skills evaluations. And on our report, we basically report on 4 different areas. First, we list their strengths, the things that they did really well, and comment on that. And then we comment on their areas for improvement and discuss what they need to do differently. Then we're going to outline the training that was done, and not just the training that was done, but the outcomes of them. For instance, if I retrained the technician on refracting, I'm going to include that the technician demonstrated proficiency at the end of the training. So you don't just want to report on what they were trained on, you want to see some kind of written evidence that the technician made corrective actions, and that the trainer observed them and found it to be satisfactory. The last thing we report on is our overall recommendations for them. And sometimes the recommendations might not be obvious things you might be thinking about right now. We'll discuss some of those in our case studies. Also, once your technician or we give you this technician skills evaluation, you want to make sure and put it in the employee's their personnel file. You know, it's very important to document all the training that's been done with your technicians and put it in there, because God forbid you have a lawyer knocking at your door and there's some problem. They are most likely going to want to know what training your technicians had. And, you know, we're a different field than most other healthcare fields in that unlicensed people and sometimes even uncertified people are performing these skills, and they provide a great bit of data to the physician. So that's very different than a medical assistant who just takes vitals and goes over the medications. So it really is a field that is more susceptible to lawyers asking about training. Let's talk about what could happen to your practice if you don't audit your technicians. Glasses remakes, more glasses remakes. And you know, we can't get totally rid of glasses remakes because sometimes the frame that was chosen was wrong. Sometimes they were made incorrectly by the lens manufacturer. They may use a lens material that has aberrations on it. So there's a host of things that can happen besides the refraction. But often it is the refraction. If we get our refractions down pat and the technicians know how to scrutinize their refractions to see if they make sense, we should have a lot less glasses remakes. And as you know, especially if you have an optical, it can be quite costly to do remakes. Slow workups are another thing that can happen if you don't go in and find out why they are slow. And I have a story about this in our case studies coming up. You don't know why they're slow unless you sit in with them and observe them work up. And sometimes they're slow because the patient needed to go to the car to get their glasses, or they got a phone call in the middle of the workup and the technician wasn't able to get them off the phone. Or perhaps they had to go to the bathroom in the middle of the workup, and these things happen. So if you have a technician that has occasional slow workups, I wouldn't look real closely at them, because chances are, if they can do fast, complete exams too, that it was a circumstance, maybe an aphasic patient or a language barrier, or one of the other situations that I already mentioned. So you want to look at your technicians' workup times in a global kind of a way. In other words, take the average workup time over a period of time, maybe a week, for each different appointment type. Most of us are concerned about complete and comprehensive exams. So you could just look at those, and that will give you some good ideas of what their average workup time is. And the reason why you have to look at the average workup time is because some workups are going to be on a 2015 patient with, you know, a small complaint and no medical history, and those are going to be fast. You could probably do one of those in 10 minutes. Or you may have a patient that has a lot of medications and they're not a good historian, or they have a lot of complaints and they have a lot of meds to update, and that is going to take much longer. This is why don't look at a single workup and jump on your tech about it being longer. Look at it over a period of time and average it out. The other thing that can happen with if you don't audit, is misdiagnoses. And we're going to talk about that coming up as well. And this all can increase your liability risk. Here's our case study number one. There was this large practice in Alabama. They reached out to us because they had an inordinate amount of glasses remakes that was costing their practice tens of thousands of dollars. Additionally, their pressures were off. The doctors were finding that technicians' pressures were not accurate. And all of these problems seem to have occurred over the previous year. Now, this practice owned their own opticals, so they're taking the hits on all these remakes. So I went into the practice and I watched the technicians work up, and immediately I found that all technicians were refracting incorrectly, and this resulted in wrong prescriptions. So if you don't have clinical knowledge, I'll just explain this, that there is minus cylinder equipment, which is usually used by optometric practices, but not always. And then there are plus cylinder phoropters that typically ophthalmologists use, but not always. So they were refracting on plus cylinder phoropters, but they were using the minus cylinder refracting technique. So all of their refractions were inaccurate. Additionally, I rechecked their pressures and I found that consistently they were about 3 to 4 or 5 points lower than what I got. And that was across the board, all the technicians. So I then had one of the technicians explain to me that they had gotten a new trainer a year ago. And of course, that rang a bell with me because the practice told me these things have been going on for a year. So I assessed the trainer skills. And I found out she had no idea that what plus and minus cylinder were. She had only worked in a practice which had minus cylinder phoropters, and she didn't even know that plus cylinder phoropters existed. She didn't understand the difference. So when the trainer came to work in the clinic and train the technician, she thought they were refracting incorrectly. And so she, quote, retrained all the techs. Additionally, she had been aligning the glaucoma Myers when we checked tonometry, the eye pressure, incorrectly. And this resulted in falsely low, by about 3 or 4 points low, eye pressures. Now, this is a problem if we have a glaucoma patient and your doctor thinks that they're well controlled on their current drop regimen. Maybe their pressures have been going up, and because the technicians aren't checking accurately, the doctor may not initiate new treatments for that patient to help keep their pressures low. So because this happened over a year, it's quite possible that glaucoma patients' visions were impacted by this. Here's the next case study. We had a practice in California who had one technician who consistently took 1 to 1.5 hours for each comprehensive exam. Other technicians were having to work up more than their fair share of patients, and the coworkers began to resent the slow technician. So the practice called us in. We ended up doing skills evals on everyone, but this particular technician was kind of brought to our attention. And typically when we go into practices and do skills evals, we don't want any bio of the technicians or for you to tell us what's wrong with them. We want to go in unbiased and evaluate them for ourselves. And then if the problem is what you thought it was, that just gives you some confirmation that you know what you're doing and you are on the right track. And that's always nice to hear. So we went in and I evaluated these techs, and I sat in with the slow tech, and her skills were clinically sound. She was doing everything according to best practices. But what I noticed was that she did not trust the patient's responses during the exam. So she always redid each test. For instance, if she's refracting and you ask sharper 1 or 2, and the patient says 2 very confidently, you should just trust that they know what they're doing. As long as they are mentally competent, they should be giving you good responses. And a technician can discern the difference between 2 or maybe 2. That's very different. Those 2 responses are very different. But this particular tech didn't trust what the patient said, so she did all the skills twice, including the refraction. This, of course, doubled her workup time. But even worse, the technician did not know how to navigate the MR, and she did not know how to type. So she was hunting and pecking at the keys to enter any data. This, of course, extended her workup time dramatically. So I reassured her and I explained to her how to tell if a patient is giving you a good response versus a I'm not sure response. And I talked to her about how she has to learn to trust her patients and their responses. And I recommended more EMR training plus an online typing course. Here's the next case study. I went to a large practice in Texas, and this actually is a practice that we've worked with over the years many times. We've done new hire training for them, skills evals, a myriad of different services. So this actually was this past spring, and they wanted skills evaluations with gap training for 18 of their technicians. So I went in and I saw the first technician, and she was working up a comprehensive exam. And when she got to confrontation visual fields, which is a side vision test to check for visual field defects, she was turning the lights off in the dark, completely black. And the test involves the technician holding up different number of fingers in different parts of their visual field, and the patient telling them how many fingers they see. Well, needless to say, even a layman understands that that doesn't make any sense at all. Additionally, the trainer had retaught the patients to check ocular motility, which is eye movement, with the lights off again, completely dark. Well, what you do with this technique is you have to move a stimulus, typically a pen or pencil or your finger, into different gaze positions. And then you have to look at both of the patient's eyes in each of those gaze positions and make sure both eye went fully and completely into each of those gaze positions and that the eye didn't overshoot or undershoot into that area. So this test can identify neurologic problems, cranial nerve palsies, strabismus, and visual field confrontation can identify brain tumors, glaucoma, strokes. And so obviously none of the technicians, because they were turning the lights off, found any of this pathology. And I can guarantee you that over a year's period of time, there were patients that came in with pathology that would have been found with these two techniques if they had not been trained to turn the lights off. So the trainer was in the break room and he was training 5 new techs. And they actually have our clinical training program, which they purchased so that their trainer can train techs. And he was in the break room doing that. So I went and I told the clinic manager what I had seen, and she could not believe it. Her jaw literally dropped. And she said, well, the trainer is in there training 5 new hires. I need to pull him out of that training. So I pulled him out and I did a skills evaluation on him. And indeed, he did those 2 skills with the lights off. And I asked him, I said, and his other skills were pretty good. And I asked him, I said, why did you turn the lights off for those 2 skills? And he thought, and he was thinking, and then he finally said, I'm not sure why I do it that way. And I said to him, don't you think that it's hard to detect the number of fingers you're holding up if it's dark? And he said, yeah, I guess so. He had just never thought about it, which is kind of surprising to me, but he hadn't. So there's a couple of problems here. One, they hired a new trainer. 2, they did not do a skills evaluation on that person before they hired them. I recommend every technician that has experience has a skills evaluation done by your really best trained technician. And I recommend getting a front office person to be the quote unquote patient, because us techs, if you get a tech, we can't help ourselves. We're going to move the equipment around and all that stuff. So get a front office person who doesn't know the equipment. And then they're going to do a comprehensive workup on that quote patient while an experienced technician is watching. So this gives you an idea of what remedial training you may need to provide for this technician. And if they're really good, it may give you reassurance that they really know what they're doing. So you want to do this before you discuss offering them a job and before you discuss pay. Because if they're going to need some remedial training, you probably don't want to hire them at top pay. Like I am fine doing remedial training on a hire, but not if I'm paying them full pay. So that's something you really want to consider doing before you hire any experienced technicians. You can head off a host of problems if you do that. Case study number 4. This is an interesting one. So we had a practice in New York who wanted their technicians' skills evaluated. I found some surprises that no one but patients knew about. This technician did not like sitting down during workups. During her EMR data entry, her derriere was in the patient's face, about 6 inches from their face. And the technician wasn't aware of it. I wrote a little note to the tech because I never embarrass techs in front of patients. And I wrote a little sticky note and I said, your derriere is right in the patient's face. And she was like, oh my God. She gave this look of mortification on her face to me. And she turned around so that her rear end was facing towards the door rather than the patient. And when the workup was done, I asked her why she didn't sit down. She said, I just prefer to stand, even when I'm entering data at the desk. So no one would have discovered this unless a patient had complained, but they never had, or someone like me was observing her workups. So can you imagine how that impacted your patient's experience in your office? It's just not a good look, not a good thing. So she corrected it after I pointed it out to her. And I'm sure her patients were a lot happier. All right, I'm going to talk just for a moment about eye tech training, what we do, who we are. So we are a team of consultants. Most of us are COMTs or we're COTs getting our COMTs. And we provide every kind of training any ophthalmology practice would need. We recently brought on 2 new trainers and they have additional skills that the others of us didn't have. So we're actually able to offer even more services now. Some of our new services are manager training and leadership training. You know, most mid-level managers don't get training before they're put into that role. And that's a real oversight. And it puts them at a disadvantage from the get-go. And then we also offer now LASIK sterile assisting training. We also have someone on our team now that can train in fluorescein angiography, including the injection, and in B-scan biometry, which we never had that in our team before. So we also do all of our regular things, all kinds of skills. We have a new hire boot camp that gets your new hires up, trained, and working at patients in 4 days. So the 5th day, we're off the floor 4 days to train them. On the 5th day, they're working up your patients, doing comprehensive workups. It's very effective and it really takes that pain off of that long, arduous training process most practices have. Here's some client feedback from our technician skills evaluations, and you can imagine how much value this brings to the practice. Now, we also sometimes have clients ask us to time the workup components. In other words, how long did the history take? How long did lensometry take? Refracting. And we will make pie charts to give to that client of each workup that the technician did so they can start developing a kind of benchmark for how long a workup should take. And in our experience, it should be about 23 minutes. And that's in line with what the national other people in our field reports, about 20 to 23 minutes. And again, remember taking that as an average. So a lot of information you can garner. Some you would be surprised to hear from skills evals. And you don't know what your techs are doing when they go in and shut that door. And you'd be shocked at some of the things we have seen. All right, back to our webinar. So some of the benefits of doing technician audits, and I recommend that you do them biannually, every other year, is better patient care. Your providers will have good data to make the best treatment plans for each patient. You should have faster throughput, especially if you've coached your slower techs. Better patient satisfaction because they're going to wait less and fewer glasses remakes. You're building a skilled clinical team, and this is not an easy thing to do, especially in this day and age where we can't typically find trained technicians to come on board. And building your clinical team in a strong way is really important. And when you really create expectations of excellency in workups and excellency in everyone's jobs, people are proud to work for your practice. Also, you should have less overhead because when we have to do glasses remakes, that takes a technician time. You have slow technicians that make clinic run behind. That means that they might run into overtime. And it's not just the technician that runs into overtime when the clinic runs behind. It's the scribe, it's the testers, it's the surgery schedulers, it's the optical, and it's somebody at the front desk. And so it is, really a snowball effect when you have one slow tech or a lot of glasses remakes. So this also will, as I said earlier, help improve your risk management. So there's many benefits, and I recommend doing one every 2 years on all your technicians. You'd be surprised how there's a natural human fallback in remembering the nuances of techniques. And I've seen techs who I trained as newbies, and then I went back in the practice multiple times, and that tech was still doing a fantastic job. And then 10 years after I first hired them, and after I've seen them doing all the skills with perfection, I go in and I observed this one tech, and she had completely forgot a very important part of one skill that was meaning she was going to miss any pupillary abnormalities just by the way she was using her light. There's no way she would have found any patients with optic nerve disease. So that really brought home to me. I was like, wow, I tell people to do biannual skills evals, but that just like was confirmation to what I recommended. Was I saw this tech doing that skill wrong after so many times and so many years doing perfectly. And I was like, yep, that is definitely something you have to do. So that's my recommendation. So what outcomes should you expect? Well, your provider should be able to see more patients as long as you don't have a slow provider. So this helps solve the problem of slow workups and less time correcting erroneous data. So your patients, are going to the flow will be better because things are being done correctly. And also you're going to have optimal patient outcomes because garbage in, garbage out. So your doctor gets good data, so the patient gets optimal care. Also, better patient satisfaction and experience. When you have slow workups or clinic is running behind for whatever reason, that's not a good patient experience, right? So that's definitely something that we can control. So that's why technician auditing is very important. Also, you have less liability exposure. If you have an attorney knocking on your door, they're going to want to know what kind of training your techs have had. So any training that you do of any kind, you want to make notes in their personnel folder so you have that. God forbid you have a lawsuit, you'll have that right available. And the trainer should sign off on those, by the way, too, and the date it was done. So we're going to provide a better overall experience and better patient care. So thank you for joining us today, and we hope to see you next month. This is a partying quote, which I really like. Developing routine helps the technician stay on track and be as efficient as possible. So do feel free to reach out to us. This is our contact info. Our headquarters is in Daytona Beach. If you're ever in the area, call me up and we can get together for lunch if you want. And there's our phone number and email. Our next in our auditing your practice series is going to be next month, where we're going to talk about auditing your optical. If you have an optical, you're definitely going to want to see this webinar. And if you're interested in optical audits, then you should probably want to sit in as well. And we're going to be talking about some unique ways you can take inventory and check for shrinkage and all kinds of things like that. So thank you so much for coming, and have a great rest of your day.